I think that the critical piece, I'm going to get myself a beer if you don't mind, because these sorts of conversations require a beer.
Yes.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thank you for listening to the podcast. I have a special treat for you. We are doing an episode on ethics during a pandemic. Now, a couple things to keep in mind is that this episode was recorded about a month ago, and it is a snapshot of time, which of course you know that the COVID-19 pandemic is evolving every single day. So there may be some information on here that may be a little bit dated by then. Or if you're listening to this in the future, this may be a little bit completely dated. And we may have found things that have already worked out, or who knows. So keep that in mind when listening to this episode. Now, this episode features one of my favorite guests to have on the podcast, and that's Dr. Lisa Wolf. As you know, you guys know Dr. Lisa Wolf. She is phenomenal. She is a specialist in research. She is an emergency nurse, a researcher, an author, an all-around total badass. So I really hope you enjoy this episode. You'll hear in the episode that we mentioned having recorded this episode before, and we did. We recorded this episode before, and then we decided to go ahead and re-record it to give it a little bit better coverage than what it got previously. But if you want to hear that first episode, it's going to be made available on YouTube. It'll probably be available in the next day or two. Just go to my YouTube channel at Art of Emergency Nursing, and you'll find it there. Keep in mind that I was on a little bit of a tear there, and that one's got a little bit of adult language in it. This one does too, so if you're listening with kids, this may not be the episode for you, but I still hope you enjoy. Enjoy the episode, and thanks for listening. Oh, but first, a disclaimer. The views, thoughts, and opinions expressed in this podcast solely belong to Dr. Wolf and myself, and do not necessarily reflect our employers, our organizations, or anyone else for that matter. So there you go. Let's do this. Enjoy the episode. What I think would be interesting, would be an interesting take, is taking the fundamentals of ethics and applying them to the patient,
Sure.
the nurse, the facility, the community.
Right. Okay.
If you think that that's something that you could, I know it's something you can do. That's something you.
Absolutely.
That's something you're interested in.
Sure.
So.
Well, I think it's important to kind of lay it. This is the, I think the critical piece. I'm going to get myself a beer if you don't mind, because these sorts of conversations require a beer.
Yes.
So I think that a lot of what people want to say, this kind of boils down to the same thing that came out in our moral distress paper. And everybody kept asking us, well, why is this not just, nurses being pissed off? How does this become a moral problem, or an ethical problem? And it's about disciplinary obligation and ethical obligations. And when they cannot be met, you're moving into an ethical or a moral realm, not just, I don't like working here.
Yeah.
Right. And I think organizing it by ethical principles and settings is a pretty good strategy, because people want to be able to make the argument like, this isn't right. But why isn't it right? Like, we live in this sort of post-truth environment where everything's your opinion.
Yeah.
Right. And I am firmly of the opinion that that there are more objective ethical truths out there.
I think that's the kind of thing that people need to hear in general. Because I think,
right,
I think so many.
This is not a matter of opinion, right? Like,
yeah.
There's things.
Yeah. So where do you want to start?
Well, where do you want to start? Do you want to start with like overarching ethical principles? Do you want to start with code of ethics? Like, what do you want to talk about?
Where's a better place to start? Overarching or code of ethics?
Well, yeah, I think we can talk a little bit about overarching.
Okay, let's
ethics,
start with overarching ethics.
So
what I want to talk about is ethics as it applies to pandemics. Not because we have a lot of experience with that, right?
Sure.
But yeah, let's talk about it.
Right. So there's two ways of looking at this. Like there are two sort of large camps, right, of ethics, and you've got deontologists, and that this sort of comes out of like Kantian philosophy, Kantian ethics, which really focuses on using the right process to make a decision, right? And there are Kantian absolutes, and those are things like it is never okay to, right? It's never okay to use person as a means to an end, right? It is never okay to sacrifice, people for the good of not people, right? Those sorts of things. They're absolutes. They are never okay.
Yeah.
And so what deontology as a framework focuses on is, are you making is the process correct, right? And so the outcome is less important than the process. And this becomes important when we talk about pandemics and opening things up and whatever, right? The other camp is utilitarianism, right? So it loosely it's like the ends justify the means, right? If you have the outcome you want, it's okay to get there by, whatever means, right? Okay. So when we apply this to the current situation, right? You've got one bunch of people saying like, it is never okay to sacrifice people to the gods of capitalism, right? It is never okay to say loss of life is okay to support something else, right? The economy, a political ideology, or whatever. All right? Even at the cost of, in this case, financial detriment, right? So yeah, people are going to be out of work. And yes, those sorts of things are going to happen, but we cannot for a moment say that is more important than not putting people deliberately in harm's way when we know that harm is potentially lethal. Does that make sense?
It does.
Right. So the other camp is sort of, this kind of falls in this situation into this kind of, really neat divide, right? With people who are like, well, yeah, sure, some people are going to die, but I'm going to, be able to go back to work, and I'm going to be able to support my family, and my ability to support my family, my right to support my family supersedes the rights of other people to remain safe. Right? Okay. And you are depriving me of some inherent right, to my own ends. Right? And so the people on the deontology side of this are going like, that's insane, right? It's never okay. That's a terrible reason to offer people up to probable morbidity and mortality because you want to, whatever, your right does not supersede that of everyone else's, right? I mean, the same argument, is applicable in a lot of different situations. Does the right of the individual supersede the good of the group?
Okay.
Right. So I would say not always. Yeah. So in this case, so those are sort of the two general camps that you can look at. And to be honest, I tend to fall more personally into the deontology group. But, in a pinch, I can usually see the utilitarian argument as long as it doesn't involve people dying, right?
Yeah.
And in this case, because the stakes are kind of high, just the idea that, a 2% collateral damage mortality rate is okay is just like horrifying, right? Like, no, that's not okay in any universe, right?
It's kind of a lot. So those are kind of a lot if you're getting to be that 2%.
Right, exactly. So like, how many of those people, like, why don't you go to the local elementary school and why don't you pull a classroom full of kids out and kill them? because that's essentially what you're doing when you say my right to walk around is, my right supersedes the negligible rights of, 30 other people.
Yeah.
Right. So those are your two big overarching groups. Now, within those ideas, right, we have a code of ethics for the profession, right? So putting your own, religious or ethical ethos aside, right, which may or may not align with either of those. Most of us are pretty flexible, to be honest. But the professional oaths that we all take, even if you didn't really think you were doing that, right? When you sign up for the job, you agree to abide by the ethics of the profession, regardless of your own personal feelings about things, right? And this is why we say to people, well, you will take care of patient X, even though you don't approve.
Yeah.
Or you don't like them or whatever, right? So those same kinds of ethics apply and they're enforced across the discipline. So in this case, this kind of harkens back to some work that I did during the Ebola pandemic, which never reached the United States, but I'll tell you, we were way better prepared for Ebola than we were for this, both ethically and with equipment and training and stuff like that. So during that time, there was a lot of discussion around, did providers have the right to decline to practice at that time? Like, could you just sort of tap out during the pandemic?
Yeah.
Or could you refuse to accept Ebola patients to your facility or whatever, if that were to come, right? So this was all really theoretical. Except for that hospital in Dallas, which was not theoretical. But so what we came up with, really, we kind of really hammered it out. And the idea that there is a duty to treat, right? So it is our obligation. There is a duty to provide care. And that applies to both physicians and nurses. So you can't say, no, I'm not going to take care of those patients, as long as that duty to treat does not violate the duty to self, right? So you have the duty that you have to provide safe, effective, compassionate care to a patient also applies to yourself, right? And so the idea there is that we are not martyrs, right? We are professionals. We are not martyrs. And therefore, if the risk to our own lives is untenably high, and I would also argue over a long period of time, right, the duty to treat is abrogated, right? It is attenuated. It is less enforceable, right, from an ethical standpoint. Yeah. So in the case where we have nurses being floated to units, that they are not comfortable in, that they are taking care of patients that are much more acutely ill than they are used to taking care of. Right? You float an endo nurse to ICU. Like, are you kidding me? Right? So, although most of them are old ER nurses, but so that's a piece of it. But the whole PPE issue is really the thing that, to me, abrogates the duty to treat. Because if you are not safe in the care of your patient, then you are able to say, you know what, I'm not doing that. And you're not, in that sense, violating professional ethics, right? So what we saw a lot of, I want to say the last time we talked, which was about 3 weeks ago?
Yeah, about that.
A lot of people kind of putting out this idea that this is what you signed up for, right? You're totally committed to your patients, and you're no matter what, and this whole thing, right? And I would argue that that's not an ethically tenable stance, right? This is not actually what any of us signed up for. This to go into a dangerous situation with really very little protection in a virus that nobody knows anything about, really, and it's getting weirder and weirder the longer time goes on.
Yeah.
And the institutions that employ us and that give us guidance, right, are not doing their jobs. And those are jobs that they are ethically obligated to do, right? So there is also a provision in the ANA Code of Ethics that really applies to managers and administrators, and that is to provide a safe environment for nurses. And so in that sense, this whole idea that I would make the argument that in institutions that are not giving nurses appropriate PPE, they are complicit in the morbidity and mortality of those staff, right? So this is not a situation where you're giving the equipment and somebody's misusing it, or some unforeseeable weird thing happened and somebody got infected and died, right? Like, that's a terrible thing, but not the fault of the institution.
Yeah.
But when you have an institution that it becomes clearer and clearer that that this is a highly communicable viral illness, and they're sort of downgrading the level of PPE that's required, because due to supply chains, right? Like, not due. And this is where deontology and utilitarianism kind of clash, right? If you're a deontologist, you say you must protect them absolutely. Like, you must stick to the standard.
Yeah.
If you fall below the standard, regardless of outcome, you are at fault, right? The utilitarian is kind of like no harm, no foul, right? Like, we're doing the best we can. So you can't really blame us for that.
Yeah.
And you kind of can, right? So from an ethical standpoint, I would say there's a whole lot of bad behavior happening around here. So I think in terms of nurses, right, there's definitely the obligation to treat. There's the duty to provide safe, effective, compassionate care, but not if you're putting yourself at high risk of contracting a potentially lethal illness. And the thing is also, like, we sort of compare this to the firefighter, right? Running into a building and, grabbing babies and puppies and, old people and stuff, right? If that person made a personal decision at one point to go into a building prior to whatever, a safety check, having the appropriate gear, whatever, right? If one firefighter made that decision in a moment of urgency, then okay, right? We'd be like, hey, the guy's a hero or the girl's a hero. But if the fire department said, hey, we expect you to do this every single time you go into the building for like the foreseeable future,
we'd
all be like, that's insane, right? That's absolutely insane. And I think that comparison kind of holds, right? It's not just the disease, it's the fact that nurses are exposed to it over and for the foreseeable future, and so the risk grows commensurately.
Yeah, it's just crazy that I didn't want to get off on the tangents again because I think we went through this all last time.
Well, we got the organized part, so it's okay.
That's right.
You've got something in the
That's
organized
right.
part.
There's something there. It's just crazy that, one of the things that just drives me crazy is that every fucking natural disaster, every fucking major health issue seems like it's the first time we're doing anything. Like,
well, yeah.
Like every single time it seems like, oh, hey, guess what? Holy shit, bad shit's going to happen. And we're like, wow, this is crazy. Who would have thought? We're like...
Right. Well, I think that's really the terrifying thing in this particular situation, is that we've got an overarching leadership that is so ethically bereft in their duty to care for the citizens, right? Like, the social contract is not just something. The social contract, as the way it was initially designed, is between the governed and the the government and the governed. It is the obligation of a nation's leaders to protect the populace. That is the social contract. In return, we will not overthrow you and chop your heads off. Like, that's the deal. And I think somebody needs to alert our government that, like, that's the deal.
Yeah. Well,
so there's all kinds of layers of that same duty and obligation to care for, right? To protect, to provide succor to, right? And we're not seeing that, like, on multiple levels.
Yeah.
Which is why I think for nurses this feels so bad.
Yeah.
Right. It feels, I think, what I'm hearing certainly from colleagues is that the sort of the extensiveness and the depth of this clusterfuck is just so morally painful, right? They can't provide care to patients in the way they want. They are not being cared for as professionals in the way that they want. And those two things together, I think, I'm really concerned that there's going to be, I hope that rather than an exodus, we have a revolution. I would rather see nurses rise up and say that is absolutely never going to happen again to us.
Absolutely.
Versus people just sort of leave.
Yeah. And that's what I hope happens too. I hope that I think that the world is going to change. The world is going to change after COVID.
The world has already changed.
You're right. It's already changed, and I think it's going to stay changed. And there's going to be, a year from now, we may not have been able to predict the changes that are coming. But one of the things I hope that more than anything, I hope nursing changes. And I hope nursing, like, you're right, bands together and say, okay, never again. Like, we are going to be the voice of healthcare. We are going to unify and be like, okay, this is how we're going to be doing this from now on.
Right. And yeah, I mean, if you could get this so that you had a healthcare system, essentially run by nurses, right? That was patient focused and nurse driven. Like, hey, I'm out of my depth. Doc, why don't you come on over here and help me out?
Yeah.
Right? Because there's just so much this particular event, right? If we think of this as sort of a global event, this has really laid bare the deficits in the system, right? Like the really scary ethical deficits in how healthcare is provided, in how governments view their citizens. Like all of that, it's like really pulling the curtain back.
Yeah.
And I kind of hope that people remember this when it comes time to decide how they want to move forward, right? Like you could just be like, oh, thank God, it isn't me. I didn't die. My family didn't die. I still have a job, We'll just, cross our fingers and hope it stays okay.
Yeah.
So.
Yeah, it's crazy to think. You have so many people, and the hard part is, and this way may what makes it hard is, there's nurses that aren't dealing with any of this. Like they're not, like they're doing okay. They're maybe slightly inconvenienced because of what's going on around them, but they're not getting killed. They're not getting their ass kicked. They're not laid off. They're not worried about whether or not they're going to not only get exposed, but then expose their family to something.
Right.
There's nurses that aren't dealing with any of that. And then there's other nurses that are dealing with all of it. Right.
So the issue is really, is it a case of those nurses are not experiencing this yet, or is this?
And that's the thing is, is this, are we not avoiding the wave, but postponing the wave?
Right.
And,
right. And so
I want to be like cautiously optimistic and think, okay, maybe this is all going to be, better. But then the other part of me is like, no, it's just going to be later.
Yeah, I think it might just be later, which is kind of rough.
Yeah.
But we can't. I think the thing is we can't abandon the ethical framework under which we practice, right? Like you can't just be like, well, in this situation, a situation is like a natural disaster, right? It's a couple of days or a couple of weeks of doing the best you can with what you have, right? Like all of us can do that.
Yeah.
All of us can do that. But being told essentially like, guess what? There's no help coming, right? Good luck getting those ventilators, that equipment. People are making like drug deals in garages trying to get N95 masks. Like, this is ridiculous. This is a banana republic. This is not how a first world nation manages a health crisis.
Yeah.
Like, and that's the part of it that's just making me so outraged. And the fact that the CDC has walked back, that JACO has walked back on stuff that was supposed to be keeping us safe.
Yeah. And
right? They have abandoned their duty to the healthcare providers that they oversee and regulate.
Yeah.
Boo. Boo on them.
Yeah.
So that's my rant, but boo.
Yeah.
So, I think if you were a nurse and you were trying to make the argument that like, hey, using a sock as a mask is just not okay. You can truck out and you have an ethical obligation under the ANA Code of Ethics to provide nurses with a safe working environment. This is not a safe working environment.
Yeah.
Now, if you gave me proper PPE, I'd be out there. Absolutely.
Yeah.
Absolutely. But knowing that due to, whatever set of circumstances, right, I'm going to be exposing myself to this all day, every day for the foreseeable future, like, I can't say I'm a fan.
Yeah.
It was more fun just to yell and swear, wasn't it?
It totally was.
It was way more fun.
Way more fun.
Look at that.
Yeah, the last one was a little sweary. So
you're swearier than me.
Totally. 100%.
You totally are.
100%. So
yeah. So from like an organized academic point of view, that's the argument.
Yeah. So what should nurses be doing? How do we do the best we can in our little corner of the world?
Yeah, it's a good question. And I think when we look at the nurses that are refusing assignments and the nurses that are threatening to strike and the nurses that are, saying, holding themselves up and saying, you provide us with more staff or we're not taking report. I think that those people are really brave. I think that the healthcare system, and you and I have talked about this before, the healthcare system is built on the ethical commitment of nurses and physicians to not abandon their patients.
Yeah.
Which is why they're able to get away with this now.
Yeah.
Right? Like any other industry, in situations that were this unsafe, they would be like, yeah, nope, sorry, not doing it. Yep. Not doing it. And because, and I think this kind of speaks to the sort of the martyr camp, right? Like your patients above all. That's sort of this higher calling, right? Like this is what makes nursing not just a job. Right? Mm-hmm. It really makes it a vocational experience. It makes it a calling in a certain way. And I think that nurses as a group I'm gonna paint us with a very broad brush, tend to want to fix things and to help and to, to a certain extent, put their own needs aside.
I think that's probably a fair, generalization. But I think
sure. But I mean, like, why else would you do it, right? Why else would you go into nursing?
No one's doing it. No one's doing this just for the money. I mean, well, maybe there are, but not.
Maybe there are, but they're kind of few and far between, right?
Yes.
But that's why administrations and governments and regional agencies can say, like, you're going to do it for the patient, and boy, are we proud of you. And like, that's starting to grate on me a little bit. I got to say, the whole, like, we love our first responders, give us some fucking PPE.
Yeah.
Right? Like, take God love them all, right? But take your clapping and your cheering and your marching bands and your flyovers and go to the White House and demand we get properly protected. Like, that is an effective use of mass opinion, right?
Yeah.
Like, it's awesome that people are sending lunch, right? Like, do what you can. I totally get that, and I appreciate it, and I think it's wonderful. But the collective power of all these people who will take half an hour out of their day to go and clap for nurses coming off of shift, pick up the phone. Take 5 minutes of those 30 minutes and call your representative. Or it's hard to protest, right? It's hard to protest when you have to stay 6 feet away.
Yeah.
But there are, this is the beauty of the internet. You can fill somebody's inbox. You can call them until their answering machine turns off, right? Yeah. You can create a mark of need in the digital world that also never goes away.
Yeah.
Right?
It's true.
And so, I think that because we are so well trained to kind of like, it really, we have talked about the ER as kind of like this abusive relationship, right?
Yep.
Where you just get your ass kicked and then somebody sends you lunch and you're like, oh my God, I love my job, right? They love us, right? They're trying to kill us, but they'll feed us first. To really pay attention to that dynamic, right? How safe do you feel where you are? And does, like, pizza for lunch fix that? Because it kind of shouldn't. That's a little dysfunctional.
Yeah.
Right? So I think recognizing that dynamic is like step one. And I think collectively, right, as a group, your unit, your shift, your pod, your shift, your unit, your hospital, your local chapter, right? Like, all of this just builds and builds and builds. And frankly, we've got ENA has a great government affairs group, right? Richard and Robert, awesome. And they work really hard, and like, call them, and ask them, what's going on the Hill? Like, who is the person I need to be calling?
Yeah.
Right? Who are the people that need to hear what's going on? Right? And, that's another way to sort of channel that need, right? It is using your time to better the situation for everybody.
Yeah.
Right? And in that way, you're kind of doing the reverse utilitarianism, right? You're saying, I'm going to sacrifice 5 minutes of my time or half an hour of my time to benefit my colleagues all over the country. Right? So that's a feel-good ethical moment, really.
Yeah, absolutely.
So that's, I think that's a big thing. I think that the nurses in Detroit are having a really rough day. They're having a really rough day. But I think that their decision to not accept a dangerous assignment is completely supportable.
Yeah.
Professionally speaking, right? It almost feels like, no, I don't know what the follow-up on that is.
I don't either. So
I don't either. We should probably find out. But
I sent her an email and said, hey, I would love to talk to you.
Mm-hmm.
And he was
Right.
like, I'll let you know.
Right. Well, that's a lot of unwelcome attention, I
That's a
think.
lot of unwelcome attention, and probably, probably doesn't, probably a little intimidating, and he very well may be being told, shut the fuck up and don't talk about this.
Right.
So,
Right.
for whatever reason, so.
Right. Another piece of this that I think is important for people to think about is that a lot of nurses are the primary breadwinners for their families.
Absolutely.
Right? If they lose their job, then who's going to feed their kids, or who's going to take care of their families, or who's going to pay for their houses, right? Like all that stuff. So again, the power gradient here is so enormous between individual nurses and administrations with the power to fire them, that between that and sort of this understood ethos of sacrifice, right? It's really hard to say, no, I will not do this. No, this is not safe. No, I will, give up my, job at this point to make this point, right?
Yeah.
Everybody's kind of just hoping that they keep their head down and hoping that they don't get sick and die, or bring it home to their elderly parents or immunocompromised spouses or whatever, right?
Absolutely.
And so, there's a lot of power imbalance that makes the non-protection of staff even more ethically egregious when you look at the actions of administrations that are not adequately protecting their staff.
Yeah.
That's like an academic rant. That's using the big fancy words instead of saying those assholes. Look.
Okay, look who's getting sweary now.
That's what a PhD gives you. The vocabulary.
Note to self.
Note to self, get PhD.
That's right. So, interesting. I don't know. It's going to be interesting to see where this all turns out, isn't it?
Yeah. Yeah, it really is. And I really hope, like I said, I hope people, support wholesale revolution rather than flee the profession screaming.
Yeah. I hope so too. I hope that there's I hope that there's not a mass exodus. I hope that there's a mass, a revolution in some way of, hey, you know what, this is never going to happen again, and here's kind of how this is going to go.
Right.
That's what I would like to see nurses say and do. But in reality, time will tell. And I don't know. The scary thing about COVID-19 is like, what's the end point? Like where's it going? We don't even know.
Right. There's some promising news out today though, which is nice.
What? I didn't hear the promising news.
That remdesivir, which is antiretroviral, actually has some clear positive effect on slightly reducing mortality and shortening the course of the illness. But I was talking to a friend of mine today. In this study, they gave it to people who are really sick. Like they gave it sort of at the end of the course of the illness.
Die. Let's try this.
Let's try it. Right. When in fact, it keeps viruses from replicating. Right. So the idea is to me anyway, like this is not how the study's going, but like from my understanding of how this works, like it would be a much better idea to give it sort of when people came in and got their rapid nasal swab, and tested positive and say, here, we're going to give you a dose of this now before you get actually
sick.
Like really sick.
Yeah.
So like Tamiflu, but for something that'll kill you. So, so I don't know. I mean, Fauci was saying that like, when AZT was shown to exert a positive effect. Like it wasn't a game changer at first, but it's the thing that you build on.
Yeah.
Right. So maybe a little bit of light at the end of the tunnel.
That'd be all right. We'd take it.
That'd be okay.
That'd be okay.
Yeah, I'll go for that.
Yeah.
Mm-hmm.
All right. That was good.
That's the deal. See, it's more organized.
That's right. That's right. The last one, I was listening to it and I was like, going, oh my God. And I was a little ranty and a little like, fuck, come on, seriously, come on. I'm like, I think we could do better than that.
We could probably do better than that.
I was like, the topic deserves something better than that. So,
yeah. But, you could also refer people and say there's a part 2 where we're really ranty and sweary. If you want to listen to that, here it is. All right. Anyways, you take care and stay safe, man.
You too. I'll talk to you soon.
Okay. Talk to you soon. Bye-bye.
Bye. Hey, everybody. Kevin here. And as Lisa mentioned, there is another version of this podcast that is going to be made available on YouTube. Be warned, there is a lot of rather colorful language in that episode. So if you have sweet, innocent ears that don't want to hear that kind of nonsense, then you just go ahead and avoid that episode on YouTube. If you're curious about what the first version of this podcast sounded like, go on over to YouTube and check it out. It should be available by the end of the day tomorrow. Thanks for listening. Hope you enjoyed the podcast.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.